What we find in a clinical setting is that what's ID'd in the lab, what's tested in the lab, what's been shown, hey, this antibiotic at this concentration in the lab doesn't always work in the patient. Just because we've designed it in the lab, we've shown that, hey, in a petri dish, in a test tube, this wipes out the bacteria. They're completely susceptible. But when we go and we try to do clinical research with that new antibiotic, it doesn't work. And for every one antibiotic that hits, there's probably dozens and dozens that just can't be used outside of a lab because of these reasons. First, the drug doesn't diffuse very well. Whether it's in the agar, whether it's in the liquid broth, whether it's in us, it doesn't diffuse very well. Something about the chemistry of the shape of the molecule of that drug interferes with diffusion, interferes with its ability to be carried throughout the body. Another thing, we sit there and we've designed many things that we think would have great antibiotic properties. Turns out when we go and we use them, well, turns out Mother Nature just slaps back too readily. What we think it would be a great antibacterial, antimicrobial, because on paper, in computer models, it worked great. So we design it, we make it, and then we test it, and we find out that the microbes are resistant. Turns out that Mother Nature had something similar to it, hundreds of thousands of years ago. So the microbes already have mechanisms that counter it. Or what we thought was the mode of action, turns out we were incorrect. It's one of the problems. Many people who aren't in the sciences, aren't in the clinical research, they say, well, we don't need to do animal testing, we don't need to do human testing, we just design it in the computer, make it, use it. Well, turns out that the models, the computer programs are limited by our intellect. And when it comes right down to it, as I tell everybody, I've told, tell all the kids, people are stupid. We can only design the computers, the programs, the models to what we think, what we know. And what we know is very little. Turns out that some infections, it's not one bacteria present. It's 2, 3 dozens of bacteria. Majority of them there are okay, part of the normal flora, they'll be wiped out. 1, maybe 2, maybe 3 that are present are pathogens. Great. Your antibiotic you're using is based on what the ID lab found. The ID lab was only able to isolate and identify one of the pathogens. The other 1 or 2, 3 species that are pathogenic, that are also present in the wound, in the infection site, they were unable to identify because they couldn't cultivate it or they disregarded it. And then there's patient mistakes. Come on, if you've ever had to take medication every 4 hours for 7 days, 3 times a day for 10 days, patients forget. And unfortunately, patients decide they're better. So they take the antibiotic for 2 days, they suddenly feel better, the swelling's down at the infection site, so it's all healed up nicely. I can stop taking the medication. They stop prematurely. They don't take it the way they're supposed to. If it's something that needs to be taken with food because, hey, for whatever reason, with food aids in uptake, maybe because the compound's hydrophobic, not hydrophilic, things like that, but they just take it on a dry stomach with a glass of water, not with food, malabsorption of it, blah, 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 blah. All these happen. As a clinician, yes, you have some of this stuff in the back of your mind as you're trying to determine which medication to use. But we also have to take into account what's referred to as the therapeutic index, cost benefit. What's going to be the cost? What's going to be the benefit? If cost is high, but benefit is low, that's an antibiotic. That's medication you don't want to use. The cost is going to be some level of toxicity, some level of damage to the patient. Benefit, it's going to clear out the infection. So what you want is to find an imbalance that goes the other way. Very little cost, very little toxicity, high level of effect, high level of bacterial death, high level of bacterial damage. They call this the minimal inhibitory concentration. What's going to be the best level of effect this antibiotic is going to have, and well, what concentration is it going to hurt the patient the least? Therapeutic indexes, the higher the index number, the better that antibiotic is. If the concentration, you pick a concentration that has a high level of toxicity, but also has a high level or a low or high to low level of therapeutic help, well, that's an imbalance. That means when you divide the inhibitory, the effect concentration by the concentration that causes toxicity, you're going to be, 1, 2. This is going to be your ratio. But if you flip it the other way, concentration that's toxic versus the concentration that's inhibitory, well, or the concentration that's high and low, it's all in a ratio. As a clinician, you want to look at what's referred to as the therapeutic index. It's a ratio of concentrations. Here's the concentration that is considered to be toxic. But at this concentration, this is the concentration you want to be able to give to your patient. Cost benefit. Here's the cost. At this concentration, it's going to be damage. Here's the benefit. I only have to use this level, though, to be useful. When things start to become equal or imbalanced the other way, that's a drug you need to sit there and question. High concentration, that's toxic. 50 milligrams per ml of compound X is toxic. 5 milligrams per ml is what you need to give the to the patient to treat the infection. That's a ratio, toxicity over therapeutic, the MIC, minimum inhibitory concentration. That's a ratio of 10 to 1. For every 1 milligram, you have to go 10 higher, 10 times higher to get toxic. 5 to 50. Higher the number, the better. Because if it gets lower and lower, compound Y, toxic at 20 milligrams per ml. But you have to prescribe it at 15 milligrams per ml just to get a therapeutic effect. You're now down to a therapeutic index of 1. Compound X, compound Y. In a clinical setting, which one's going to be better for the patient? The 10 to 1, the 10, or the 1.2? Toxic level, 15 milligrams per ml. minimum inhibitory concentration, the therapeutic, 30 milligrams per ml. You're now at therapeutic index of 0.5. That means that whatever, however you go to use this, compound Z with its therapeutic index of 0.5 is going to be toxic to the patient if you go and try to use it as a treatment. Always want to go for the higher the therapeutic index, 10 to 1, 20 to 1, 100, and stay away from anything that's too low.